This second lecture video for Unit 3, we're going to talk about antibody detection. So once we do testing to determine if a patient has an antibody, and if we determine that they do have an antibody, we have to do further testing to determine what that antibody is, so that we can issue products for transfusion that will be safe for that patient. Okay, so just a little bit of an overview. The antibody screen or antibody detection testing is one of the most important tests in pre-transfusion and in prenatal testing. And the reason for that is that this testing that we do is to detect clinically significant antibodies in both donors and transfusion recipients. So if we have a patient who has to have transfusion of blood products, we have to make sure that, number one, that the patient doesn't have antibodies, or that if they do, we can identify what that antibody or antibodies are so that we can find compatible products to transfuse to them. And then in the donor, if we've got folks who are donating red blood cells or other blood products, we have to make sure that they don't have antibodies that could potentially be passed on to a recipient. Okay, so unexpected antibodies, those are going to be the ones that are outside of the ABO blood group system, because if you remember when we talked about the ABO blood group system, the antibodies from that system are naturally occurring. So for instance, if you are a type A person, you have the A antigen on your red cells, you would naturally produce anti-B or antibodies to the B antigen. So those are naturally occurring. Unexpected antibodies form in response to transfusion or exposure to fetal cells during pregnancy or delivery. Allo antibodies are antibodies that are directed to a non-self antigen. So those are going to be ones that are acquired through transfusion or pregnancy. Autoantibodies are those that are formed against a person's own red cells. This is usually due to a disease process. It could be also in response to certain types of medications. And we talked about autoantibodies in the previous lecture. Auto-anti-I is a fairly common cold reacting autoantibody. And antibody identification requires knowledge of antibody and antigen characteristics, as well as reagents that can aid in identification. So we talked about that in the previous lecture also. So not only does it help to know, or at least have access to, those frequency charts to determine how likely is it for this patient to be producing this antibody based on the frequencies of antigens present in their race. Knowing if an antigen or an antibody is cold or warm. So is it going to react optimally at room temperature or cooler temperatures, or is it going to react optimally at body temperature? So in other words, is it an IgG or an IgM antibody? Is this antibody enhanced or destroyed by the use of enzymes? So knowing that information about those characteristics of the antigen and antibodies can help you identify an antibody that could be present in a patient. Okay, the antibody detection. So this, the purpose of this testing is to detect potentially significant antibodies in a donor or a recipient sample. Only 0.02 to 2% of healthy individuals have antibodies versus 14 to 50% seen in chronically transfused patients. So, I mean, if you think about it, if a patient is in a position where they're undergoing treatment for some type of condition that requires repeated or frequent blood or blood product transfusions, that increases the likelihood that they're going to be exposed to a foreign antigen, so an antigen that they do not have on their red cells. And when they're exposed to that foreign antigen, they can build antibodies. So patients who will have antibody screens, any patient that requires a transfusion, patients who are having a suspected transfusion reaction, women who are pregnant or after delivery, blood and plasma donors, patients with autoimmune hemolytic anemia, and patients with graft versus host disease or other complications of organ or stem cell or marrow transplants. So any of those patients, we would be required to do antibody screening testing on them. Okay, the antibody screen, also referred to as the IAT or indirect antibody test, incubates the patient's serum or plasma with reagent screening cells. We incubate at 37 degrees Celsius, followed by an IAT or antibody panel for detection of any IgG antibodies that are found in the screen. The screen cells are made up always of group O reagent red cells. So individuals who donate blood, they can use that blood to create these packages of screening cells that we use as reagents in the labs. But those antibody screen cells and then the antibody panel has to come from group O individuals. And why do you think that is? Group O individuals do not have any naturally occurring antibodies, so there would not be any antibodies, naturally occurring antibodies that could react with the patient's sample. Okay, so the antibody screen incubates the patient serum or plasma with the reagent screening cells. Those screen cells come in packages of either 2 or 3 cells. So they're like little vials of reagent red cells. So the package will either include 2 screen cells or 3 bottles of screen cells. Whether you're using the 2 or the 3 cell screen panels, they're both going to test for the most common clinically significant antibodies. And most of those are going to be the ones that, the ABO antibodies, and then the ones that we talked about in the first lecture video of Unit 3. The initial spin phase is usually not performed in a screen because antibodies at this antibodies that are positive at this phase are usually not considered clinically significant. So the initial spin or the room temperature phase of testing is going to detect your IgM antibodies because of those are the colder reacting antibodies. But remember that IgM antibodies are typically the ones that are not going to be clinically significant. They're typically not going to cause transfusion reactions. They're just going to cause issues during the testing. So a reaction to one or more of those screening cells indicates the presence of an atypical antibody. So it indicates that the patient has an atypical antibody. The difference in the 2 and 3 cell screening panels, the 3 cell screening panel is going to include a D negative cell and a homozygous cell for Duffy and Kit antigens so that we can see dosage if it's present. You have to pay careful attention to the screen cells because that can save time when you are proceeding to the full antibody panel. So what happens is we initially do that screen, antibody screen, and if it's, because it's a quicker way to detect if a patient has an atypical antibody. And since the majority of the population does not have antibodies, we can do this quick test to determine if the patient does have an antibody. If the patient is found to have an antibody, that's when we move on and do the full panel identification, antibody identification panel. So if the patient, during the screening testing, if the patient reacts to one or more of those screening cells, that indicates the presence of an atypical antibody, we have to move on to the full antibody panel. False positives in testing can result from Rouleau antibodies to a preservative in one of the reagents, from fibrin, sample contamination, presence of cryoprecipitate from frozen samples, PEG, which is one of our enhancement reagents. So PEG, if the reactions are read at 37 degrees Celsius. So before you move on to that full antibody panel, before you do all this additional extensive testing, you might want to investigate the patient's diagnosis, some of the methodologies that you've used, or maybe even obtain a new sample for repeat testing. Now, I didn't realize I've got two of the same slides in the PowerPoint. Sorry. Okay, so this is an antibody screen antigram. So you can think of the antigram. So this is a piece of paper that's going to come in the package with the screening cells. It'll also come with the full panel cells, but the full panel is going to have, so this is cell 1, cell 2. So this is a 2-cell screening package. And again, you can have 3 cells screening packages also. The full panel antibody panel cells will have 10 or more. So you would have this, it would be the same antigram, but with the phenotypes for all 10 of those donors. And that's what this indicates. So this is one donor who has contributed to the red cells that are used in this reagent antibody detection kit. This is the second donor. So it's showing you the phenotype of this donor, which antigens they are positive for and which antigens they are negative for. So what you're doing when you're testing this, these donor red cells against the patient's serum or plasma, if you have a reaction, you can go back and look and see, okay, if the patient is reacting with the D cell for both, with both donors, then that means, because this indicates the antigen, these donors have the D antigen on their red cells. So if our patient is reacting, that means that they have to have the D antibody, because antigens and antibodies react to form agglutination. So you can use this phenotype, this map here, to compare to your patient results. That's how we determine the identification of the patient's antibody. So these screening cells, they're licensed by the FDA. They require this antigenic profile that's capable of detecting most of the clinically significant red cell antibodies. So again, these are most of the ones that we talked about in the first lecture. Okay, so some different screen interpretations. So each one of these shows you a different scenario. So what they've done is they've used, they've got an antibody screening panel that they're testing, and each one of these is a 3-cell screening panel that they've tested against a patient, and they're showing you the results that they've got from their testing and what that indicates. The different results that you can see at the different phases of testing shows what type of antibody that indicates. So for instance, in this first screen here, we've got no reactivity at initial spin. We've got no reactivity at 37 degrees, but we do have some reactivity in cell 2 at our AHG phase. So CC stands for check cells, and remember we add check cells to all tubes that have AHG that give a negative result. So we've added check cells to tubes 1 and 3 because we got negative reactions in both of those. And the little check mark just means that we got the reaction that we were expecting, which is agglutination. And then we have gone over here to do it. Since we have a positive antibody screen, we have to perform a DAT. So this column is the results of the DAT testing. So they tested with polyspecific AHG, and then individually with the IgG and the C3. So the poly was negative, which means that NT stands for not tested. So because the polyspecific was negative, there was no need to test the monospecific reagents, which are the IgG and the C3. So how do we interpret this? So this indicates, because we've got reactivity in one phase of testing, which is the AHG, and in only one cell, with cell number 2, this indicates an alloantibody of the IgG class, because it's reacting at AHG, single specificity. So this means it's likely just one antibody because we're only seeing reactivity in one cell. Okay, with the second scenario, we've done the same testing, but we're seeing some different results here. Okay, initial spin, no reactivity in any of the cells. At 37, though, we're seeing reactivity in screen cell 3. It's a 1+ reaction. But then when we get to AHG, we're seeing reactivity in all 3 of the cells, and we've got varying strengths of reactivity. Okay, so we had a positive antibody screen, so we have to perform the DAT. Polyspecific was negative. So because polyspecific was negative, we don't have to carry out the testing for the monospecific reagents. So what do these results indicate? Again, alloantibody, IgG class, because we're seeing reactivity in the warmer phases of testing. Multiple specificities. Okay, so how do you determine that it's multiple specificities? Because of the varying reaction strengths, and you can see with screen cell 3, whatever this antibody is that's reacting, it's reacting at 37, but then it's reacting stronger after the addition of AHG. So that's where you have to know those antibody reactivity characteristics. So which antibodies react at 37 but then might have a stronger reaction at AHG, which antibodies react only at AHG. So, and you know it's an alloantibody because the DAT is negative. Okay, moving on to the next one. We've got reactivity in all 3 cells of the initial spin. No reactivity at 37 or AHG, and because all of our AHG tubes were negative, we added check cells and we got reactivity, so we're good there. So initially, if I was looking at this and I saw reactivity in all phases of the initial spin, I might be thinking that it's an IgM autoantibody, but when we do our DAT, it's negative. So that tells us it can't be an autoantibody. So we've got an alloantibody of the IgM class, single specificity. So whatever that antibody is, it's present in all 3 of the donor screening cells for the patient to react at. Okay. In this next one, again, we've got reactivity in all three cells at initial spin, nothing in 37, nothing in AHG. So we add our check cells, we get the reactions that we're looking for. So all of that's good. But the difference between example 3 and example 4 is in the DAT. Our polyspecific is positive. So in this case, we do have to continue on and carry out our monospecific testing for IgG and complement. The IgG tube is negative, C3 is positive. So because our DAT is positive, this indicates an autoantibody. It's still IgM class because it's reacting at those colder temperatures. So we would label this as a cold autoantibody. We still would have to determine the specificity of that antibody, but we know we've got a cold auto. And then in the last example here, no reactivity in any of the cells at initial spin or 37, but we've got reactivity in every cell at AHG phase. And because the AHG tubes are positive, we're not adding our check cells. We do our DAT, it's 2+ positive polyspecific, but this one's positive for IgG instead of complement. So again, we've got an autoantibody because our DAT is positive. It's of the IgG class because we've got reactivity at the AHG phase. So we're going to label this a warm autoantibody. And a lot of times you'll have reactivity in every single cell in the case of autoantibodies. So you have to pay attention because this one's positive in every single cell, but our DAT is negative. So that's what tells us that it can't be an autoantibody. So this is just some examples of different reactions that you could get during your screening testing and how you would interpret those reactions. Okay, so some causes for false positive and false negatives in antiglobulin testing. So false positives could be if the red cells are agglutinated before that wash step and before the addition of the AHG reagent. So if they're already agglutinated before that, but then you're reading that reaction after that wash step and after the AHG, then they're still going to look like they're agglutinated. If you're using dirty glassware, there might be some particulate matter there that looks like that you misinterpret as agglutination. Improper centrifugation, so specifically over centrifugation. So if you over centrifuge either at a higher speed or for a longer time, it's going to pack those cells in tighter, which may make it, when you take them out of the centrifuge and you gently resuspend, because they've been so tightly packed, they might not resuspend the way that they're supposed to. So it might look like there's agglutination there when really it's just that the cells were packed so tightly together they're having trouble dispersing. Okay, and then reasons for false negatives. If you don't wash the cells during the test procedure before you add the AHG, so in this case you would have unbound human serum globulins that neutralize that AHG reagent. If the testing gets interrupted or delayed, so if you fail to add your AHG reagent immediately after the wash step, or you forget to add it at all, maybe your testing got interrupted and you forgot to add it. So those bound IgG or complement molecules could detach from those coated red cells. If you've got weak positive reactions that you're calling negative, so you just have to pay very close attention to those reactions. Loss of reagent activity. So one of the things that you do on a daily basis in the blood bank lab is check all of your reagents to make sure that all of the expiration dates are still in date, that nothing looks out of the ordinary about the reagents. So if reagents are stored improperly, if there's some type of bacterial contamination, it could cause our reagents not to react properly. failure to add the AHG. So that kind of goes back to up here. Improper centrifugation. So under centrifugation will give us a false negative. And it's just the opposite of what I said for over centrifugation. It's not pushing the cells together as much as it should. So we're not getting that optimal, the conditions that are optimal to promote agglutination. And then inappropriate red cell concentrations. So our suspensions should, when we make our red cell suspensions, they should be between 2 to 5%. So if your red cell suspension is not made correctly, the concentration of those red cells influences that agglutination reaction. So that's why we want it in that optimal 2 to 5% range. Okay, antibody detection. So autocontrol and the direct antiglobulin test, or DAT. So I talked about it a little bit when we were going through those scenarios a few slides ago. So the autocontrol and the DAT are going to provide important information about the specificity of that antibody. So the autocontrol tests the patient's serum with the patient's red cells. And if you've used any kind of potentiator like LIS or PEG during the other phases of your testing, you would use it in the autocontrol also. It also usually gets incubated with antibody ID panel and read in the reaction phase appropriate for whatever potentiator you're using. The DAT is performed on the patient's cells without serum. So you're going to centrifuge your sample and separate your serum from your cells. It also is going to use that potentiator and an incubation step if it's appropriate. Usually you're only going to do the DAT if the autocontrol is positive or if the test was ordered by the physician. Only IgG and monoclonal DAT would be performed on babies because they can't yet form complement. So DAT is one of those tests that automatically gets performed on babies. But on adults, you would not perform it unless the doctor has ordered it, or if the autocontrol or if the antibody screen or antibody panel is positive. Okay, so potentiators and alternative methods in the antibody screen and antibody procedures. So these are just kind of additional reagents that we've got at our disposal that can help us with antibody ID. So they increase the speed and sensitivity of the antibody attachment to the red cell antigen. And then each method is going to have advantages and disadvantages. So I'm not going to go through each one of these, but just kind of read through. So I've got your potentiators listed here, how they're commonly used, some of the limitations of each of those methods, and then different enzymes that can be used, how they react and some of the limitations. And then these two, gel technology and solid phase, are just different automated methodologies and some of their advantages and disadvantages. So just read through those. And for these, for your potentiators, your LIS, your albumin, and your PEG, usually a lab is only going to have one of these that they use regularly. Some bigger labs, or like the Red Cross where they're doing tons and tons of testing, might utilize all three of those. Okay, patient history. So has the patient had a transfusion within the past 3 months? Are they pregnant, or any other type of medical history that might be relative to the blood banking testing that we're doing? Patient information such as their diagnosis, race, age, certain diseases are associated with the development of certain antibodies. And like we talked about in the first lecture, some antibodies are going to be more common amongst different races, or maybe even in different age groups, populations. An example of diseases, lupus or carcinoma, can be associated with warm autoantibodies. Pneumonia can be associated with cold autoimmune antibodies. Sickle cell patients can have multiple allo and autoantibodies. So it can be helpful to have that information about the patient when we're trying to figure out what the antibody is. Okay, so just like with the screening cells, our full antibody panel cells also consist of group O cells from donors who display the most common antigen phenotypes that we would see in the general population. So those panel cells could include 10, 11, 15, 16, or 20 cells. So they're packaged as a set, and just depending on which set your lab utilizes, it can have different number of reagent donor cells available. You would use the same potentiator as the screen with an auto control included. And again, the auto control is just going to help us determine if it's an allo antibody or an auto antibody. So you've got a suspension of the patient's red cells with the patient serum incubated along with the panel cells read at the same reaction phases as the panel. So it determines if the patient has formed an antibody against his or her own red cells or against transfused red cells from a recent transfusion. A negative autocontrol would indicate the presence of an allo antibody. If the patient has a positive autocontrol, it indicates the presence of an auto antibody. Okay, when the autocontrol is positive, the DAT should be done to determine if the red cells have bound globulins. So positive autocontrol and a negative DAT can indicate a false positive due maybe to the type of potentiator that was used. So you could try using a different one, or the DAT could be negative due to a low affinity antibody from a recent transfusion. Okay, the ID panel comes with the antigram, just like the screening cells do. So, and it's that antigram or that map is unique to each panel lot number. And so those antigrams are not interchangeable in between the different kits or packages of panel cells. Agglutination in each phase of testing gets interpreted and recorded on that antigram. All your negative results are confirmed with check cells. And remember, check cells are just IgG sensitized reagent red cells that we add to our negative AHG reactions. Okay, so some guidelines for interpretation of your panel. So your auto control, you want to look, well, and this is true, reaction strength. Hold on, let me go back. Auto control, so is it negative or positive? If it's negative, that indicates an allo antibody. If it's positive, that indicates an auto antibody, potentially maybe some type of drug interaction. Could be a delayed transfusion reaction where transfused cells are sensitized with antibody. The reaction strength, is it a single strength? So for instance, are you seeing reaction strengths of 1+ all the way through, or do you have varying strengths? So do you have some cells that have a 2+ reaction and some that have a 3+ reaction? So this can help you determine, is it one antibody specificity, or do you have more than one antibody present, or could it potentially be an antibody that's showing dosage? And again, that if the panel cell is homozygous, and again, we see this probably most often in the M and N blood group system. If the panel cell is homozygous, then you're going to see a stronger reaction with homozygous cells versus with heterozygous expression. So an example, if the donor cell is M positive, N negative. That means they inherited both M copies and no N copies. So they've got a stronger expression of M. So that's a double dose, which is homozygous. And if the patient has an anti-M antibody, you're going to see stronger reactivity with the donor cell that exhibits homozygous expression versus the donor cell that exhibits heterozygous expression. So if we're testing our patient who has an anti-M against this donor cell and this donor cell, we're going to get stronger reactivity with this one versus with this one, because instead of having 2 doses of the M antigen, they've got 1 of each, which is heterozygous. So it's going to be a weaker expression. I thought I had I guess I didn't do a slide for it, but reaction phases also you have to take into account. Is the reactivity that you're seeing in what phase of testing? So is it in at room temperature initial spin? That indicates that you're dealing with a cold or an IgM antibody. Are you seeing reactions at 37 degrees? It could be an IgM if your reactivity started at room temperature, but it's more likely an IgG antibody if your reactions were not seen at room temperature, but you saw them at 37 or at AHG. And then the antibodies that react at AHG are going to be warm IgG antibodies that will be clinically significant. Okay, so ruling out, so panel cells with negative reactions. So we've tested our reagent red cells against our patient serum or plasma. So if we get panel cells that have negative reactions with all tested phases, so that's your initial spin, your 37-degree incubation, and your AHG, those are the reactions that we use to rule out antibody specificities. Because if the patient has not reacted at any phase of testing with that donor cell, then that means that the patient cannot have an antibody to any of the antigens that that donor cell was positive for. So what you do is you begin with the first negative reaction, looking across the panel. I'm going to skip to this slide for a second just so you can see what I'm talking about. Okay, so you're going to begin with the first negative reaction. Okay, first of all, let's look at all of our reaction phases here. So this is initial spin, 37, AHG, and this is for our check cells. And it says up here they used LIS was the potentiator that they used. This is an antigram that's similar to what would come with your package of antibody ID panel cells. So we're testing each one of these is a different donor who has contributed to this 10-cell package of antibody ID reagents. So with each one of these donor cells, we've combined donor red cells with our patient serum or plasma, and then we've recorded the reactions at each phase of testing. And again, all of these results tell us information about the donor. This is the phenotype. So donor number 1 has the D antigen, has the big C antigen, lacks the big E antigen, lacks the little c antigen, and so on. So from our patient reactivity with these donor cells, this is how we determine antibody ID. Okay, so back to ruling out. So we're looking for panel cells with negative reactions with all tested phases. So we're not going to use this one because we have a positive at AHG. So this one is not negative at all tested phases. However, cell number 2 is negative at all tested phases. So we're negative at initial spin, negative at 37, negative at AHG. You're not looking at the check cells. We can't use cell 3 because we have a positive reaction. But cells 4, 5, and 6 we can use because we've got negative reactions at all phases of testing. We can't use cell number 7 in our rule out, but we can use the rest. So what we do, we're going to begin with the first negative reaction. Looking across the panel, we're going to place a line through any antigen specificities that are positive. So this is our first negative reaction, the first reaction that we have negative reactions at all phases of testing. So then when we were looking across to the donor's phenotype here, and we're going to cross out or place a line through any antigen specificities that are positive. Okay, so for instance, this donor is positive for D, so we can rule that out. Negative for big C, so we're not, I know there's a line there, but they've done it with another one of these negative reactions, but it was not from this one. So positive reaction here, so we're going to cross that out. Positive reaction here, so we're going to cross out little c. We would not cross out little e from this reaction. And then so on. So you're going to do that all the way across with the reactions, antigen reactions from donor number 3. I'm sorry, I'm on the wrong line. Donor number 2, because that's where we had the first incidence of negative reactions in all phases of testing. So once we do our rule outs with that one, we're going to go down to the next cell where we have all negative reactions. So that would be cell number 4. And we're going to do the same thing. We're going to come back over here. We had already crossed out D from cell number 2, but it's negative here anyway. We had already crossed out big C from cell number 2, so we don't have to cross it out again. Negative here, so there's no cross out. Positive here, so we would cross out little c. And we had not crossed out little c from cell number 2, so we're going to be crossing it out from cell number 4. So, and again, you're going to go all the way across the number 4 cell line there and cross out the antigens that are positive. And the reason for that is that if the antigen-antibody reaction was negative, then the antibody that the patient has that we're trying to identify did not react with the antigen on the panel cell, so it can be eliminated as a possible antibody. Panel cells that are heterozygous should not be crossed out because the antibody may be too weak to react, or it might be exhibiting dosage. So it's preferable to rule out using homozygous cells if possible. So that's where that homozygous versus heterozygous expression comes into play. And let me see if I can find an example of that on here. Where are my M and N? Okay, so we're in cell number 2 again, where our patient had negative reactions at all phases of testing. And if we come back over here to M and N, which show strong dosage, we've got the donor cell is positive at M, negative at N, which means that they inherited 2 copies of M, none of N. So this is an example of homozygous expression. We can see the dosage in the cells that are positive. So we had positive reactivity in cell number 7. Go back over to M and N. We've got stronger reactivity with M than with N. Let's see if that's true here too. That's not true here. So this antibody is not going to be M or N. We've already crossed it out anyway. And what they've done in this example, they've gone through and crossed out all the antigens that are not possible antibodies for this patient, And then Lutheran A and kale is what they've ended up with. And you can see, because Lutheran A is such a low incidence antigen, none of our donor cells have are positive for Lutheran A antigen. So really we could cross that out because we're having reactivity with our patient. So if the donor cells are all negative for Lutheran A, there's nothing there for our patient cells to react with. So really we could cross Lutheran A out also. But if you look at kale, you can see that we've got, and this does show dosage. So they've identified the antibody that the patient has as an anti-K or anti-kale. And we've got reactivity here where we had reactivity with our patient. Donor number 2 lacks the kale antigen and we didn't have a reaction here. Donor 3 has the antigen and we had a reaction here with our patient, and so on as you go down the line. So once you have ruled out all of the antigens that you could possibly rule out, the next thing that you're looking for is if you've got some antigens that you have not ruled out, do any of the patterns match the reactivity that you obtained with your patient testing? And kale does. We've got a positive, positive, negative, negative, positive, positive, negatives, negatives, positive, positive. So this pattern matches perfectly, and we're seeing dosage. So the big K and the little k get inherited together, but this donor has one of each. So that's heterozygous expression. We've got 2+ reaction. Same here, heterozygous expression, 2+ reactivity. But down here, we've got homozygous expression because they inherited 2 copies of the big K, none of the little k. We have stronger reaction here. So that's showing dosage. So once you've done all of your rule outs, that's where you look for those positive reactions and match the pattern. When a single antibody is present, the pattern of reactions should match one of those antigen columns. If you've got more than one antibody as a possibility, you can determine antibody frequency for a patient population, and you could potentially rule out based on that. So for instance, if Lutheran A can't be ruled out, you know that it's a very low frequency antigen, and that's what's happening here. So the probability of producing an antibody to it would be very low. So confirming that antibody ID requires a certain number of panel cells which lack and express the antigen corresponding to the antibody's suspected specificity. So our standard is 2 antigen positive panel cells that agglutinate and 2 antigen negative panel cells that do not agglutinate. This is known as the rule of 2. When I went through school, it was the rule of 3. We had to have 3 positives and 3 negatives. And some labs may still do rule of 3, but I guess rule of 2 is kind of the standard now. So if you don't have enough cells in the panel to determine statistical confidence in the specificity, you could use additional cells from different panels to meet that rule of 2. So, if you're using additional panel cells from another panel, it has to be a different lot number. Otherwise, they're going to be the exact same cells that you're testing against. That additional panel is referred to as a selected cell panel or a rule out panel. Okay, so for the rule of 2, what it's saying here is we've got 2 antigen panel cells that agglutinate. So this panel cell is positive for kale and it agglutinated. This one is positive and it agglutinated, and same for number 7. So we have 3 panel cells that are positive for kale that have agglutinated, and we have more than 3 that are negative that did not agglutinate. So it meets that rule of 2 or rule of 3. Something else that we can use is the patient's phenotype. So a patient cannot make antibodies to antigens that they have. So additional confirmation of antibody ID can be done by testing the patient's red cells for the identified antibody. So if you phenotype your patient, you test your patient to determine if they have, say you've gotten it down to, just for instance, let's say we were not able to rule out kale, and maybe we're not able to rule out Duffy A. If we're not sure which one of those it is, we can phenotype our patient's red cells. If they have the Duffy A antigen on their red cell, they cannot make the antibody. So we could rule Duffy A out based on the patient's phenotype. But if the patient was negative for the kale antigen, then we know they could have potentially built an antibody. So we know that that's a possibility. You can only do phenotyping if the patient has not had any recent transfusions. So that's why we ask the patients, have they been transfused or pregnant within the past 3 months? Because transfused red cells can stay in circulation for 3 months, so it can affect our reactions. Okay. If a patient has multiple antibodies, so use of selected cells can complete that rule of 2. And again, if you can't meet that rule of 2 on your initial antibody panel, you don't have to test an entire additional panel. You can just take the cells that you need to confirm to meet that rule of 2, and pull those couple of cells from that other panel and just test those. You can do an enzyme panel, so that can be used to eliminate or enhance antibody activity. You want to do it at the AHG phase to avoid false positive reactions. And so this is where you have to know which enzymes, how they react with certain antibodies. So for instance, if you were trying to prove that the patient had a KID antibody, well, KID is one of those antibodies that is enhanced with enzymes. So you could use the enzyme and see if you get a stronger reaction with the KID antibody after the addition of the enzyme. And then conversely, Duffy, for instance, is destroyed by enzymes. So if you weren't sure if it was a Duffy or not, and you added the enzyme and the reactivity goes away, then that's a good indication that it could be Duffy. Enhancing, if you've got weak IgG antibody reactions, you could repeat the panel with a different enhancement medium. Maybe that'll give you stronger reactivity. You can increase the serum to cell ratio. You can increase the incubation time, but you don't ever want to incubate beyond the manufacturer's recommendations for whichever specific reagents that you're using. And then you could also start with a fresh sample from the patient and retest. There are some antibodies formerly known as high titer low avidity antibodies, or HTLA. They were a collection of high incidence antigens with a characteristic agglutination patterns. So some of the antigens that are linked to this high titer low avidity antibodies, you can see a list of them here. I'm not going to mention them all. So some of the characteristics of those high titer low avidity antibodies, they'll have weak agglutination, so that's the low avidity part. So weak agglutination at AHG phases of testing. You're going to see reactivity with all or most of the panel cells. A lot of times these antibodies are going to be found in conjunction with other antibodies. You might see variable reactions in your panel cells. They're not usually enhanced with PEGLIS or enzymes, non-reactive with autologous cells. Reactions could be weaker on older red cells. And then titration and neutralization might be useful techniques to classify and identify antibodies that are in this group. But again, we don't see this very often, but these are some of those characteristics that might lead you to believe that you're dealing with an HTLA antibody. Okay, and this is the end of this lecture, and we are going to practice doing some of these rule out panels in class. The blood bank guy has a video on doing rule outs, so if my explanation did not make sense to you, I would encourage you to find his video, watch it, and then we will be practicing in class.